it is my great pleasure to hand over to Dr. Guirish Solanki, who is a consultant pediatric neurosurgeon at the Birmingham Women's and Children's Hospital in the UK. He's also the director of the Regional Neurosurgery Training Program and chair of the West Midlands Specialty Training Committee for Neurosurgery. In addition, Dr. Solanki is the chair of the British Pediatric Neurosurgery Group. Dr. Solanki, the stage is yours.
Yeah, I do apologize. There is a small lag between us and you. Unfortunately, I'm calling you from the hospital, so there's a huge use of the bandwidth, and sometimes the connection may slow down. So I apologize in advance if there is any slowing of the presentation. Jennifer, thank you so much for your kind introduction. I would like to, first of all, thank Leica and Associates for setting up, which I'm honored to be part of. My role is relatively small. I'm going to talk on advancing surgery in pediatric brain tumors, and particularly the role of fluorescence-guided surgery, and in particular, the use of 5-aminolevulinic acid in that. I have no significant disclosures to report. I have no personal shares of financial interests, but I have received support to learn and get certified in the use of 5-ALA, the users have. I've received equipment support from Leica and honoraria from Leica Microsystems to participate in the symposium. And what I would like to do today is, first of all, talk about the obstacles that are present for all surgeons when dealing with resection of pediatric or even adult brain tumors. Second, I would like to talk about the pharmacodynamics of 5-ALA and how this would affect the fluorescence in tumors particularly. Then I would like to talk a little bit about the evidence on pediatric brain tumors, and then take you on to the optimization of surgical resection, usefulness, how we connect, for example, and combine modalities. And finally, I'd like to take you on to what's on the horizon, and particularly how does optical imaging affect the fluorescence, because it's light-based. So without much ado, let me now start by a very short introduction on pediatric brain tumors. We all know that gross total resection improves survival or longer progression-free interval. And to achieve that, most neurosurgeons will now work on improving and overcoming the surgical challenges to safe and complete resection of tumors. And this includes getting adequate illumination and magnification, which is an absolute standard of care now, operating through a safe surgical corridor to avoid neurological deficits, and precisely locating and determining the extent of brain tumors. So those are the real surgical challenges. We have pretty much conquered most of this. So image augmentation and illumination, for example, starts, if you think about, we just had some augmentation of glasses and then went on to loops. And then since then, we've started using fixed microscopes. And of course, since then, high-resolution 4K microscopes we've gone on to image-guided surgery, ultrasound-guided surgery, intraoperative MRI scans, and all of this have helped us locate and guide tumor surgery to a high level of precision. And the intraoperative MRI has reduced the reoperation rates by ensuring the maximum extent of resection during each procedure. So fluorescence, oh please, can you close the door? Fluorescence is the new level of precision. So FL400 fluorescence filter used with 5-ALA during resection procedures allows precise differentiation of tumor tissue from healthy brain tissue. And this is at the touch of a button. Before I go into the use of 5-ALA, I wanted to speak to you a little bit about 5-ALA metabolism. Now, the 5-ALA is a natural biochemical precursor of heme that is metabolized in a series of enzymatic reactions to photosensitive fluorescent porphyrins, porphyrin 9. Porphyrin 9 is transformed to heme after insertion of iron by the enzyme ferrochelatase. And the mechanism of tumor fluorescence using 5-LA has been well described, but not all factors leading to it are fully understood, and further studies are needed. So here is an example of the mechanism of 5-LA. As you can see, normally the heme synthesis as a rate-limiting step because of a feedback loop that prevents excessive formation by the enzyme ion chelatase. Now, if you give excess exogenous 5-LA, this blocks the negative feedback control and results in accumulation of protoporphyrin 9 in the target tissues. And that then can be used for photodynamic diagnosis. Here's an example of what I'm talking about. You can see that the 5-aminolevulinic acid in the normal tissue and then becomes heme. So protoporphyrin 9 is a precursor to heme. There is a feedback loop based on free iron. Now, if you give exogenous 5-amino or delta-aminolevulinic acid, the synthesis accumulates, protoporphyrin 9 increases in quantity. This then results in excitation at the 375 to 440 nanometer light, with re-emission at 635 and 704 nanometers. This then leads to fluorescence of a red color, as you can see here, and the ferrochelatase deficiency prevents inflammation. So fluorescence emission also can be classified, and Tumors and colleagues have worked on this and defined, for example, that intense, or what we call the solid red fluorescence, corresponds to vital solid tumor tissue. Vague or pink fluorescence corresponds to infiltrating tumor cells, and violet blue light appears blue for normal brain lacking enhanced protoporphyrin 9 levels. And you can see here the very center is bright red, then there is a vague pink fluorescence around the center, and then the violet blue is normal brain. So what do we know about 5-LA fluorescence? We know that fluorescence seems to increase when there's disruption of the blood-brain barrier, because 5-LA is actually a nitrophilic substance. And those tumors who break down the blood-brain barrier, specifically the high-grade tumors, seem to have great accumulation of these fluorescent porphyrins. We also know that tumor metabolism seems to have an effect, and later on I'm going to show you some evidence that IDH1 mutated tumors increase fluorescence, and that as a specific mechanism. Well, I'll talk about it later. And then in glioma biopsies, microvascular density has correlated positively with protoporphyrin 9 concentrations, but the lack of endothelial proliferation reduces the fluorescence. So there are a number of factors that we need to be aware of in terms of when do you get fluorescence and when you don't get fluorescence. About 5-ALA fluorescence intraoperatively and MRI enhancement, there is evidence that residual tumor enhancement on MRI images is also associated with residual intraoperative tissue fluorescence. So when we change from white light to blue light, we'll see that. In unresected fluorescing tissue, at the MRI enhancement was only detected in 65% of patients. So that means that in the other 35%, the tumor that fluoresced was actually non-enhancing tumor. And therefore, it is considered that actually tumor fluorescence using 5-LA reportedly improves the extent of resection compared to conventional white light, which is either guided or not guided by MRI-based neuronavigation. This is particularly in adult gliomas, and this is reported on the French Society review of the evidence on 5-LA fluorescence. What about fluorescence in pediatric brain tumors? If we look at the evidence, there seems to be a consensus that high-grade gliomas, just like in adults, seem to fluoresce the best, and there is a 90% fluorescence. So if you take 100 high-grade gliomas, 90% of them will fluoresce really well. If you look at ependymomas, 70% of them will fluoresce really well. However, medulloblastomas, which are malignant in nature, have variable fluorescence, and only 20% seem to have useful fluorescence. And the same applies to low-grade lesions like pilocytic astrocytomas, where there is a variable fluorescence. So what are the pharmacodynamic effects of 5-LA that we need to be aware of? First of all, of course, it's an oral drug, so it has a systemic effect. And actually, protoporphyrin 9 accumulates in various epithelia and cancer tissues. W3 and 4, which are the high-grade glioblastomas, gliosarcomas, and aplastic astrocytomas, they can synthesize more protoporphyrin 9 in response to exogenous 5-LA administration. Now, the concentration of protoporphyrin 9 is significantly lower in white matter than in cortex and tumor. So the tissue surrounding the tumor, normal brain, may also be affected, but less, unless it's infiltrating. Now, if we look at high-grade and low-grade, what we know is that 5-LA induced protoporphyrin formation is significantly higher in malignant tissue than in normal brain. And in response to the exogenous 5-LA, several effects are known to occur. First, there is an increase in protoporphyrin 9 formation in malignant tumors. That does not happen in normal brain. There is an increased synthesis of protoporphyrin 9 in malignant tissue specifically, and then higher 5-LA uptake in the tumor tissue. You give from the outside, the more the tumor tissue will uptake. And so there is an altered pattern of expression of activity of enzymes as well. Example, as I mentioned before, the ferrochelatase involved in hemoglobin biosynthesis is blocked. There's a disruption of the blood-brain barrier in this tumor, so 5-LA takes advantage of that. There's increased neovascularization, and we talked about vascular density, overexpression of membrane transporters in glioma tissue. So all of these factors seem to increase fluorescence in high-grade tumors. On the contrary, in WHO grade 1 and 2, there is little or no effective or useful fluorescence under 5-LA. So in pediatric population, the first thing, of course, is safety. So the safety and efficacy in children and adolescents up to the age of 18 have not yet been established. There's no current data available. It's used off license, and the method of administration, as I mentioned, is oral, 3 hours, range 2 to 4 hours before anesthesia. The use of 5 other than the ones used in clinical trials entail an undetermined risk. If the surgery is postponed for more than 12 hours, surgery should be rescheduled for the next day or later. And another dose of this medicine can be taken 2 to 4 hours before anesthesia in that case. Now, in keeping with the issue of risk, this is in adult tumor resections and malignant gliomas, the presence of the risk of liver damage from the use of 5-LA in intraoperative identification. These are 2 papers, one from the Far East, and then more recently there's a paper on children as well. So fluorescence-guided surgery with 5-aminolevulinic acid for resection of brain tumors in children also identified significant increases for alanine aminotransferase, gamma-glutamyl transpeptidase, and this correlated with younger age. So I think it's critically important that when we use 5-LA, particularly in children, that we take extreme care to avoid liver, renal, cardiac issues, and particularly because there's evidence that those enzymes increase, patients have altered liver functions or liver failure should be absolute contraindications to the use of 5-LA. There are other drug interactions, mostly to do with the photosensitizing effect following the application of glialan. But an interesting one is the drug interactions, and particularly anti-epileptic drugs. And there's a very interesting paper that came out in Frontiers in Oncology in May of 2019, which was the role of 5-LA in low-grade gliomas and the influence of anti-epileptic drugs on intraoperative fluorescence. So I read this paper with quite significant interest because it points out that fluorescence in low-grade gliomas might be better than what has previously been reported in the literature. And this study was actually to look at that specific. And what they found is that in 27 patients with histologically confirmed low-grade gliomas, 14 were diffuse astrocytomas, 5 oligodendrogliomas, and then 4 pilocytic astrocytomas, chemistocytic astrocytomas, and 1 desmoplastic infantile range. They found that there was visible fluorescence in 52% of the patients. The cell density and proliferation rate were significantly higher in the fluorescent positive samples, and fluorescence homogeneity was evenly split between focal and diffuse fluorescence. So it appears that there is at least half of the low-grade gliomas show visible fluorescence. And that's interesting. And they looked further, and what they found is that in this group of patients, the determining factor when they stratified was anti-epileptic drugs. So of the 56% that fluoresced, 56% of the total population of patients studied were on anti-epileptic drugs before surgery. Of these, 70 showed no visible fluorescence. But the 44% of the patients that were not on prior anti-epileptic drugs, 83% of those showed visible fluorescence. So the authors came to the conclusion that visible fluorescence was significantly more common in patients without anti-epileptic drugs. And the study therefore suggests two things. One, that there is a high rate of visible fluorescence in low-grade gliomas compared to the current literature. And second, that the intake of anti-epileptic drugs seemed to reduce the presence of visible fluorescence in such tumors. And this should be taken into account in the clinical setting. When we go and talk about pediatric brain tumors, well, it has been a long road. The first use of 5-LA was way back in 1989. The first was published in 2006, 17 years later. And then regulatory approval with the EMA followed in 2007. And then FDA took another 10 years in 2017. But there is, of course, now good, at least 3 randomized control trials that show good evidence of greater gross total resection and progression-free survival in high-grade gliomas in adults. And similar responses are noted in pediatric tumors as well. And this particular systematic review, which was published in 2019 by Michael Schocke, but led by Walter's Tumors team. As you know, everybody who knows 5-LA knows Walter's Tumor. I myself went and learned the use of 5-LA from Walter. It's a very detailed, thorough study. And the idea essentially was that we pulled together 19 eligible publications, identified 175 5-LA guided operations on pediatric brain tumors, and to prevent any bias, publications were revised independently by 2 authors. And what they found is that the majority of surgeons were able to identify the tumor more easily, and this was considered useful, and that's the word, helpful, mainly in cases of glioblastoma in 78%, anaplastic ependymomas in 71%, anaplastic astrocytomas in 67%. In contrast, the lack of consistent fluorescence signal made it less useful to the surgeons in cases of pilocytic astrocytomas, which fluoresce in 12%, and medulloblastomas in about 1/5 of the cases. So they concluded that the accumulation of fluorescent porphyrins seems to depend on WHO tumor grading. LA-guided resections were considered helpful, and the degree of resection was higher, and that's important. The rate of adverse events related to 5-LA was negligible, especially new postoperative sequelae, and 5-LA could play a role in resection of pediatric brain tumors, and further prospective clinical trials are absolutely needed. More studies followed, and this particular one, which is predicting the usefulness of 5-LA-derived tumor fluorescence, again from the same team, published in Acta Neurosurgica, looked specifically at the fluorescence and how useful the fluorescence was in resecting pediatric brain tumors. And as you can see here, the blue light and the central pink or red area on the tumors were resected. What was done was that using the 5-LA European Gliolan user group, the patient characteristics, the MRI characteristics of tumor, the histology, the fluorescent qualities and outcomes were requested. Surgeons were further asked to identify whether fluorescence was useful. or leading to changes in surgical strategy or identification of residual tumor. Then what they did is they used recursive partitioning analysis, which allowed them to define cohorts with higher or lower likelihood of useful fluorescence. So in a way, a predictive analysis. So 78 patients were collected under 18 years of age, submitted by 20 centers in Europe. Fluorescence was found useful in 12 out of 14 glioblastomas, again, 85%, 60% of anaplastic astrocytomas, and 80% of the ependymomas grade 1 and 2. Fluorescence was not so useful in PNETs, 43%, gangliogliomas, 40%, medulloblastomas, only about, and pilocytic astrocytomas, 15%. So these results are very much in keeping with the pooled data that they presented subsequently. And the recursive partitioning analysis showed that preoperative factors suggest strong contrast enhancement and first operation to have a likelihood of useful fluorescence of 64.3% in supratentorial location compared with the infratentorial location with first surgery, which was only 23%. So I think that's something for us to keep in mind. So they concluded that 5-LA is now being used in pediatric brain tumors increasingly. 5-LA may be specifically used for contrast-enhancing supratentorial tumors, and this data indicate controlled studies to be necessary, as we spoke earlier. Again, another study looking at the accuracy of visible fluorescence using spectrometry, histology, and postoperative imaging. And what the authors did on this occasion was to look at resection, different microscopic fluorescence qualities like strong and weak, and to see how this could distinguish and help guide resections. So when they looked at fluorescence, they were able to tell that those that had strong fluorescence corresponded to greater spectrometric fluorescence, solid proliferating tumor, and high cell densities. The tumors with weak fluorescence corresponded to lower spectrometric fluorescence, infiltrating tumor, and medium cell density. The positive predictive value of this was 100%, and strongly fluorescing tissue, 95%, weakly influorescing tissue. When they looked at spectrometric fluorescence, this was detected in marginal tissue without fluorescence. Depending on the thresholds, displayed greater sensitivity but lower specificity. So the accuracy was less, 88.4%. And when they looked at the tumor bed, residual MRI enhancement, this was seen in 65% with residual fluorescence of the patients without residual fluorescence, suggesting that the enhancing residual tumors. So fluorescence appears superior to contrast enhancement on MRI for indicating residual tumor, as you saw on another study earlier. And studies, a very nice study by my friend Matthias Prost and his team, the use of 5-aminolevulinic acid fluorescence guidance in resection of pediatric brain tumors. The conclusion was that the off-label use of 5-LA fluorescence guidance in pediatric patients appears to be most useful in recurrent high-grade gliomas. And I think that is pretty much accepted. Fluorescence accumulation in other pediatric tumor entities is not predictable and should be studies. And this was a study done in 2013, but we know that since then, a number of other studies have come out suggesting much better, on a larger number of patients, much better results, particularly with ependymomas and mixed results with medulloblastomas and least the pilocytic astrocytes. One of the things that came out of this was what could we do to improve fluorescence, optic identification of tumors. So one was the use of fluorescin. So fluorescin, of course, is another fluorescent agent, which is given intravenously, the two simultaneously, and see whether the effect of fluorescin, which is yellow light, can be seen on white light microscopy, combined with 5-LA, which is a result of blue light, and the combination of that could have reduced the effect of the dampening of illumination and the visualization that occurs under blue light. So the authors then looked at the combination, and as you can see, I've copied some images from their paper, which are quite self-explanatory. On A, you can see the white light appearance of the resection area. On B, you can see the blue light red core of the 5-ALA fluorescence of the tumor. And on D, you can see the inclusion of intravenous fluorescin, and the periphery of the tumor lights up with fluorescin, a much better visualization of the central red area with no sort of a problem with the peripheral area. So based on that, they concluded that dual labeling with both protoporphyrin 9 and fluorescence is feasible and gives superior background information during fluorescence-guided resections. And therefore, the authors believe that this technique has a potential as a next step fluorescence-guided resection. Now, one of the interesting things that have recently been identified is the effect of 5-ALA with metabolic tumor function. There's this nice paper that came out from the Far East that specifies a mechanism for enhanced 5-ALA fluorescence in isocyanates 1 mutant malignant gliomas. So there is a good relation between 5-ALA fluorescence and IDH1 mutations in WHO grade 3 glioma. Have identified and shown that relationship. And now, just very quickly, I don't want to bore you with details, but here is citrate cycle. And what happens here is that in a normal situation, the oxaloacetates will move on to citrate and isocitrate and form alpha-ketoglutarate and 2-alpha-ketoglutarate. Is that if there's a deficiency of NADPH, that deficiency of NADPH blocks the formation and frequencies in the presence of exogenous ALA. You get an increase in protoporphyrin 9 and fluorescence. Here is an example of the normal pathway of citrate, isocitrate, alpha-ketoglutarate, succinyl-CoA, and sufficient NADPH is formed to allow smooth heme degradation and active ALA synthase. This is the wild-type IDH1. Now, in the case of the mutant, the mutated IDH1 tumor, the citrate levels go up, isocitrate levels go up, alpha-ketoglutarate levels drop, and that means that you have retarded heme degradation, repressed ALA synthase, decreased ANH production, leads to the overproduction of 5-ALA and protoporphyrin 9. And this, you can see the example here on this table where NADPH levels are normal in the control group and severely depleted in the 5-ALA group with the protoporphyrin 9. This is the table showing the association between intraoperative ALA fluorescence and IDH1 mutations. On the first row, the mutated IDH1 clearly shows a significantly higher number compared to the wild type of fluorescence. And this graph clearly shows that a number of tumors, grade 3 tumors, like anaplastic astrocytoma, anaplastic oligodendroglioma, and so on, levels of fluorescence with the citrate levels in the tumor. The relationship between 5-ALA fluorescence and IDH1 mutations in grade 3 gliomas is established and should be taken into consideration when planning surgery. In wild type, heme degradation is unaffected, and of course, in IDH mutation, the retarded heme degradation within the tumor, including and that then leads to enhanced fluorescence. One quick word about false negative and positive results. Of course, some of the non-tumor issues like abnormal brain, in reactive astrocytosis, atypical cells, necrotic tissue, inflammation, infections, such as fungal and bacterial infections or abscesses. In some of the CNS lymphomas, fluorescence may be seen in areas of abnormal tissue. Non-fluorescing tissue can also be seen in surgical field in the presence of active tumor glioma. Must not be forgotten. Now, one important thing is that we get too excited and say, oh yeah, here it is, fluorescing tumor, let's take it. But of course, where there is eloquent areas that and doing purely on the grounds of fluorescence could be dangerous and could lead to significant problems. So it's critically important that if you're using fluorescent-guided resection in these patients, like the visual cortex or near the visual pathway or the motor cortex or the Broca's area, and you know that these patients have not improved on corticosteroid treatment, then you know that these areas are already compromised or at risk and are unlikely to improve. The use of fluorescent guided surgery could actually result in more damage and loss of preservation neurological function. In those cases, it's critically important that you identify preoperative or intraoperative mechanisms to map the brain and the subcortical structures and stay a safe distance to those areas by at least 1 centimeter, independent of the degree of fluorescence. In all these patients with a tumor in the vicinity of an important neurological function or eloquent area, use intraoperative neuromonitoring or preoperative monitoring to absolutely localize the function relative to the tumor in order to maintain safe distances during fluorescent-guided resections. There are other ways you can identify 5-ALA. For example, this is a study by Walter Tumors group looking at spectroscopic measurements of 5-ALA-induced intracellular protoporphyrin 9 in pediatric brain tumors. Again, they were able to, actually using the same approach as they would in any surgery. The only difference is that they took the samples that they collected and then used spectroscopy on those tumor samples. And they were able to show that the tumor, medulloblastomas, pilocytic astrocytomas, anaplastic, there were 11 patients in about 6 different tumors. Strong fluorescence was visible in all anaplastic tumors and 1 pilocytic astrocytoma. 1 pilocytic astrocytoma demonstrated weak fluorescence. So visible fluorescence was strongly associated with intracellular fluorescence. And as we discussed before, both of these suggest the intracellular protoporphyrin 9 concentration in excess of 4 micrograms per ml was present in all those tumors that had shown visible fluorescence. And that visible fluorescence seems to be superior than than MRI enhancement in identifying tumor. I'll just say a very quick word, and I don't spend too much time, but the point here is, can we expand the use of 5-ALA fluorescence, for example, in spinal tumors? We've been talking about brain tumors, but of course, spinal tumors is a major area of intervention for neurosurgeons. Now, the data that's coming out is from adult tumors, but it's really exciting. A study that was done by one of the American groups, and what it shows, analysis of 5-aminolevulinic acid-induced fluorescence, 55 different spinal tumors. They were happy to point out that a significant number of these patients resulted in good fluorescence. They found that the recurrent tumors, ependymomas again, seemed to fluoresce the best, and concluded that the 5-ALA-based fluorescence was observed in spinal tumors, especially ependymomas, meningiomas, hemangiopericytomas, drop metastasis of primary CNS tumors. And in cases of intramedullary tumors, the 5-ALA fluorescence is a useful tool for detection of potential residual tumor forming. And I think that this is an area that probably would be replicated in pediatric spinal tumors as well. Another report talking about 9 cases of intramedullary ependymoma showing very similar results. A further review of the role of 5LA in spinal tumor surgery, again suggesting its usefulness in drop metastasis from cerebral gliomas, ependymomas, meningiomas, and hemangiopericytomas, classification similar in the brain. And again, I would say if we are using 5ALA, it's important that you carry out intraoperative MRI scans because if you have residual tumor, you don't want to do a second operation, and intraoperative MRI scans certainly would help you with that. This is a study looking at that, and it concludes that the intraoperative MRI guided resection is a powerful tool to treat 5ALA gliomas, 5ALA positive and negative gliomas, and 5ALA is useful for high-grade gliomas. And the combination of MRI and 5ALA has synergistic effects in glioma surgery. And additionally, precise tumor grading in preoperative imaging studies can be, because it can be difficult, performed using both 5ALA fluorescence and intraoperative MRI-guided resection. So that's a very nice study. Endoscopic surgery. This is a nice study by Marian Rapp and Michael Saddle's team. Endoscopic assisted visualization using 5ALA-induced fluorescence in malignant glioma surgery. Basically, what we're talking here is a standard craniotomy, corticotomy, and then you identify, carry out a complete resection of the contrast-enhancing part of malignant glioma, and then you use your endoscope to carry out further visualization. And if you find more tumor, then you go ahead and take out more microscopic, do a further microscopic resection of the tumor. And this was a nice study, and what it essentially showed is that if you use endoscopic capable 5ALA fluorescence visualization capabilities, you can increase the extent of your resection. What we can see on A is the blue light fluorescence. Initially, you can see the tumor has been resected. You can just see blue light, but actually when the endoscope is put in, a further area of tumor is now seen in the deep subcortical areas where we know fluorescence light penetrates less, and the distance between the source of the light and the target is critically important. So getting to the target improves the fluorescence, and I will talk a little bit about it later. So I was really excited to see this paper, and I think this is something that, again, could be used in pediatrics for certain. The original studies, again, this is a nice study from my colleagues in Tel Aviv, Shlomi and Jonathan. They thought that the 5ALA in pediatric brain tumors is not routinely beneficial, but could be used selectively, particularly in high-grade gliomas and ependymomas, which has been also the review by other experts on the field. So that takes us to the final part of my talk, and that is how do we improve visualization in fluorescence-guided surgery? And this is a really wonderful review by Limpeng Wei and Jonathan T.C. Liu. This is a more sort of technical presentation, and the authors have gone quite deep into how do we make fluorescence better. And they defined the tools for fluorescence as those that either are freestanding, and they provide long, wide distance, or probe-based that provide a short distance. So this is, you can, if you use a microscope, your focal length is very fixed, and you have to put your microscope to a distance where you can actually operate. But with an endoscope, for example, you can take the endoscope right down. So it's for fluorescence, and it's clear that probe-based increased fluorescence detection, and the spectral detection is also augmented. So field of view are inversely proportional. And they have therefore defined those as freestanding, as wide field microscopy, wide field spectroscopy, fluorescence tomography, against probe-based systems, the most common one being the wide field endoscopy. But of course, fiber optic spectroscopy, point scan confocal, and line scan confocal are other systems that are coming on. So what are the factors? The most important factor that the authors have described to us is what is called the averaging effect. So the low spatial resolution reduces the signal to background ratio of optical detection. And that means that if your source is out of focus, when you look into the screen, you're not going to see fluorescence because you're out of focus. So you have to have high levels of magnification to identify high level, not only high levels of magnification, but focus at those high levels of magnification to identify fluorescence. And this is one of the difficulties, averaging effect. So one of the ways to reduce that, of course, would be to reduce scatter. Now, the second problem is what is known as the inverse square law, where there's a reduction in signal collection with distance. So the longer the distance from the source to the target, the less you're going to collect the signals emitting out from the ultraviolet or blue light. The shorter the view distance, the stronger the fluorescent signal. And you can see the difference here. Weak signal, quite far away, strong signal. So this is the second issue. And then the third issue is the light scatter. So how do we reduce the light scatter to improve fluorescence? And here comes into play the confocal microscopy, which reduces the background scatter and spatial filter and provides a much higher image contrast. So all of this are applicable in practice. Now, this is an example. For example, you see in A is conventional white light microscopy, non-fluorescence of the brain. Then you apply the blue light excitation of protoporphyrin 9, and you can see that in this area of the tumor, you get a red area of tumor. And when you do an MRI scan on area D, you can see that that was the area that was enhancing as well. Now, if you look at deep tissue white light spectroscopy, this would be the area that we identified as showing up on the red light excitation protoporphyrin 9. Now, the corresponding MRI scan, again, highlights that in E, and that is at a depth of 5 millimeters. So using confocal microscopy, we can go into the deep tissues, which ultraviolet light doesn't. It goes on the superficial 1 millimeter level. So these are really exciting technologies which are developing on spectroscopy, single-axis confocal, and dual-axis confocal, which even improves further the vision. So what are the sort of summary keys here? And what I can tell you is that there is, of course, the field of view. And here in the field of view, the freestanding scopy are currently the ones that provide you with the best field of view. But when you look at spatial resolution, actually it's the probe-based systems that provide you with the best spatial resolution. So clearly a combination of those two would be helpful. But commercially, only the wide field microscopy, wide field endoscopy, and the point scan confocal are currently available. So there's a lot more room for us to make some improvement. And this is a list of clinical studies highlighting the effect of all of these tumors, the specificity and sensitivity of the various visualization technologies. Just a simple example here is a high-grade glioma. You can see the tumor on white light and then application of blue light. And as the tumor is lifted, you can see the red light of 5-ALA fluorescence guidance. And then you can see further demonstration of the tumor there with another area of red light. So this then allows the surgeon to remove those areas, and once those areas are removed, he then carries out another blue light examination of the area and finds more tumor is removed, and after that resection, you can see that there is significant improvement now, and this is the preoperative MRI scan. This is the white light and the blue light postoperative, end of surgery or end of resection MRI scan, and this is the postoperative MRI scan. So I am in no doubt that the use of these tools significantly helps us in getting a greater extent of resection, more useful resection, particularly in high-grade gliomas where there is very good evidence of effectiveness. This is another example to show you how you can use fluorescing. So this is a patient who's got a third ventricular tumor, which turned out to be a germinoma. I credit the slides to my friend, Professor Kenichi Nishiyama from Japan, who lent me the slides to illustrate the benefits of using, for example, fluorescing. So this is an intraoperative microscopic tumor, which Professor Nishiyama then he's got a great interest in endoscopy and the use of fluorescing for diagnostic biopsies. And what you can see here is the tumor in the third ventricle. And as we see, I think I can't move forward on the video, but it looks like, okay, the video is moving now. I thought the video stopped, but you can see that the fluorescent has been given. And when fluorescent is given, within 2 minutes, the tumor will become yellow and light up. And you can see the tumor becoming yellow now. And this then allows the surgeon to carry out a precision-guided biopsy of small tumors in confined areas using a different fluorescence. And of course, we talked about combining, for example, fluorescing with 5-LA if you want to do extensive resections. But in an endoscopic procedure, for example, fluorescing could be a very nice alternative option. So this is just to give you the sort of the other side rather than a complete focus on 5-LA. I think the combination is coming and it could be quite useful. This is the end of the biopsy, as you can see here. Right, so this is fluorescein 1.2 milligrams per kilogram given by intravenous injection, no filters, special lights. So I would like to conclude by saying to you that the advanced surgical microscopes like the Leica, equipped with blue light filters, the enhanced intraoperative visualization has become an indispensable surgical technique and standard of care resection of high-grade gliomas in adults. But we saw today from the evidence I presented that the same standard almost certainly will now appear in pediatrics for high-grade gliomas, very useful in ependymoma and less useful in other tumors. So I think a selective use in pediatrics would be the way forward. The studies of ALA fluorescence indicate that tumor factors like IDH1 metabolism, status, vascular density, blood-brain barrier leakage affect fluorescence. Drug interactions, query, anti-epileptic drugs in low-grade gliomas affect reduced fluorescence, and then physical factors affecting light reflection. And I think those, we will see the appearance of fluorescence-enabled endoscopes that can be used in combination with operative monitoring and intraoperative MRI becoming standard with the use of 5-LA fluorescence. A note of caution really about in children particularly, and avoid using it in patients with liver disease or failure. And then the clarification of factors associated with biological variability in fluorescence are now necessary to optimize the selective use and help characterize tumor grading, aggressiveness, and other factors. And pediatric neurosurgery oncology units around the world are including 5-LA increasingly, and ours does it as well for selective and precise resection of pediatric brain tumors. So I want to thank you for listening to me, and I'm open to questions.
Thank you so much, Dr. Solanki. We really appreciate you taking the time and being here today. Thank you for this fantastic and insightful presentation. So before we head to the questions, let's just take a quick look at the technologies that are supporting pediatric brain tumor surgery. So those are the Leica Arvio Digital Augmented Reality Microscope, the M530 OHX Surgical Microscope, and the FL400 Fluorescence Module. So if you, dear viewers, dear audience, are interested in learning more about these technologies, you are invited to request your private session by the Leica experts. You can see on the slide that there are numerous possibilities, so you can see what is the best possibility for you, and then just reach out to our Leica experts, and then you can have your private session. And I would also like to say thank you to you for your participation and for submitting your questions, which we are going to take a look at now. So the very first question is, sir, how do you combine connectome, DID, and fluorescence?
I think there's probably a typo here, but are you asking how do I combine craniotomy with fluorescence, or are you asking how do I combine two different types of fluorescence? Is it possible to get a response on that? If it is craniotomy and fluorescence, I would say that the oral drug 5-ALA is given between 2 to 4 hours in advance by mouth, and then the surgery is carried out. So there is no issue with that. If we're talking about the use of combining other types of fluorescence, like fluorescein, again, the oral use of 5-ALA is given prior to surgery between 2 to 4 hours. And during the surgery, a couple of minutes, probably about 2 minutes prior to visualizing the area that you want to resect, you can give an intravenous injection of fluorescein in those patients where there is no risk of allergies or similar. And then the fluorescein will light up and create a nice combination of the two fluorescent agents to your question.
Well, thank you so much for answering both possible questions. So now it says connectome, DTI, and fluorescence, without the typo.
Okay, so that's a nice, thank you, Jennifer. Yes, so that's a nice question. Again, DTI, diffusion tractography, is for white matter. Most of the fluorescence, as I pointed out, is cortical for superficial resection of tumors. The exciting technology would be to demonstrate subcortical tumors and identify and combine 5-ALA with the DTI technology, which I don't think is very difficult. You can plan your DTI preoperatively, and then during surgery have the DTI mapping on your intraoperative MRI data. So image-guided surgery using DTI and the 5-ALA fluorescence would be an ideal way to carry out specific disconnections and surgeries of that nature on a subcortical level. Thank you for that important question.
Thank you so much. Then let's take a look at the next question. Thank you for a great presentation, Dr. Solanki. Is funding for 5-ALA an issue for you in the UK?
No, it's of course, again, an important question. 5-ALA is now approved by NICE for use in high-grade gliomas in adults, so that's not really a problem. The majority of adult hospitals use 5-ALA regularly in high-grade glioma and other types of appropriate tumor surgery. In pediatrics, it remains off-label, and an application to the drugs counsel is required. So what we do is after using it a few times, then we will obtain approval for very specific selective tumors. Our hospital does that. It hasn't been a problem, I should say.
Okay, perfect. Thank you very much. Do we have more questions? Yes, we do. Is there an elevated risk with pediatric tumor patients with complex brain tumor cases and the use of 5-ALA?
Not particularly. It really depends on what you define as complex brain tumor. For example, large ependymomas could benefit from 5-ALA because that would show us any residual that we might have missed during the surgery. However, if we're talking about tumors which may harbor other tumors or tumors in eloquent areas, then absolutely we have to be extremely careful in using 5-ALA in eloquent sites. I mentioned the Broca's area, the motor cortex, visual cortex, the area of the chiasm, and other eloquent areas. I think here using 5-ALA alone could pose a risk to pediatric patients, and I think it's critically important that we do brain mapping, awake surgery, or other means of intraoperative monitoring. For example, we use voltage probes to identify the subcortical motor tracts. Before we do a resection, we use a minimum of 10 to 12 millimeter distance, and that's where we stop our subcortical or cortical resection to avoid any damage to the fiber tracts. I hope that answers your question. Thank you for asking.
Oh, thank you so much. Then let us take a look at the next question. Dear Dr. Solanki, what can you tell us about the treatment of grade 1 and grade 2 tumors where 5-ALA is not as effective?
Yes, that's a big, I think this is an area of expanding research. As you can see, the Russian study kind of opened the way for people to carry out research on that. There's still a lot we don't know. For example, what is the relationship between 5-ALA and BRAF fusion? I don't think that has been answered. 5-ALA and a number of other metabolic effects of the tumor, the stratification of benign tumors. So I think research is coming. But to answer your current question, how would you deal with grade 1 and grade 2 tumors where 5-ALA is not effective? I would use standard approaches. Most of, for example, grade 1 tumors, although they don't enhance as much or they don't fluoresce, they're still pretty discernible and can be very clearly resectable. The infiltrating part may not be, but for example, pilocytic astrocytomas are avascular or low vascularity, and the margin of resection is often visible. If a residual is left, it's better to leave some behind rather than damage healthy tissue, as you can always come back, or you can monitor small residual portions of the tumor radiologically until such a time as this may require further surgery. So there's no loss there. But of course, 5-ALA is coming for low-grade tumors as well, in my opinion. Thank you.
Thank you very much. So do we have time for more questions? I have another one. How do you foresee the future of visualization tools for pediatric operative neurosurgery?
So this is a really exciting question, and I suspect that this is a scientist or researcher because the horizon is really exciting. The view is stellar. So just the way that 5-ALA fluorescence came out and allows us to identify. I mean, we were doing, FISH, fluorescence in situ hybridization of tumors for diagnostic purposes. Now we're using fluorescence for treatment purposes. And similarly, we're using targeted molecules for stratification of tumor subgroups. So I am in no doubt that the next generation will be antibody-targeted fluorescence or very specific RNA probes, or what we call theranostics. They are just around the corner. So I think the future of visualization is going to be based on very specific molecular targets of very specific subclass of tumors, which will allow us to identify with great precision the part of the tumor we want to remove and leave all the healthy brain around. So great times ahead. Thank you.
Thank you very much. I'll just check to see if we have one more question. So yes, our final question is, thank you, Dr. Solanki, for your presentation. As experienced and very well-known pediatric neurosurgeon, do you have any advice for younger neurosurgeons? It's a very nice question.
I know, I think I owe this one a beer. Oh, sorry, I shouldn't say beer, not politically correct. Maybe a glass of wine or just a non-alcoholic drink. Okay, no, but more seriously, yes. I mean, absolutely, younger neurosurgeons, I think when I was at that level of training, I was always excited to hear a presentation about something that advanced our technical ability or our skill set. So I would say to you, be passionate, be excited about what you just heard, go and find a way to do better, do some research. Maybe you will discover something that others have not, and you will contribute to the fund of knowledge, even in a greater way. So I wish you the very best, and thank you for patiently listening to possibly a boring presentation that you found exciting. Thank you.
Thank you so much, Dr. Solanki, for those wonderful words. And of course, it was everything but boring. Thank you for taking the time for this great presentation. Thank you for your advice for the younger surgeons. And of course, also a great thank you to you, dear audience. Thank you for participating. Thank you for your time. And of course, also for your questions.